Hello everyone. Today's class is on oral cavity and tongue. We will also be dealing with the hypoglossal nerve. Now this nerve you've seen in bits and pieces in various lectures. We will compile it and complete it today. The competencies which will be covered are describe and demonstrate the morphology, nerve supply, embryological basis of nerve supply, blood supply, lymphatic drainage and actions of extrinsic and intrinsic muscles of the tongue. Now this part, the embryological basis of nerve supply, would be clearer to you after we've done the embryology. So we will be discussing the nerve supply, but not so much so focusing on the embryological basis as of now. With embryology, we'll focus on that particular competency. We will also be dealing with the anatomical basis of the hypoglossal nerve palsy. A 65-year-old man came to the physician, reported to the physician with complaints of difficulty in speech, which in medical terms is also known as dysarthria. He also said that he felt trembling of his tongue, that is involuntary contractions, which in medical terms is known as fasciculations, were seen. So he complained of difficulty in speaking as well as dysarthria. The physician asked him to protrude his tongue. When he protruded his tongue, he noticed that the tongue moved towards the tongue, when the protruded tongue deviated towards the right side, number one. He also saw that there was an atrophy of the tongue and wrinkling of the tongue on the side in which it deviated, that is on the right side. Now, what is the anatomical basis of the signs which you have elicited from this particular patient? We will also discuss that in this particular lecture. Now, let's first familiarize ourselves with the boundaries of the oral cavity. This is the coronal section of the head, in which we can see the cranial cavity with the two cerebral hemispheres which are present in it, separated by the falx cerebri. Below the cranial cavity are the orbits, in which are present the eyeball and all these structures with the orbital contents which we've already seen. Here is the nasal cavity, and opening into the nasal cavity in its medial meatus are the maxillary air sinuses. This is the hard palate. The hard palate is separating the nasal cavity from the oral cavity. It is important to familiarize yourself with this coronal section because we will be seeing this even when we look at the PA radiographs of the skull. Now, the oral cavity is separated from the nasal cavity by the hard palate. In its floor is present the floor of the oral cavity. In its floor is present the tongue. It is bounded anteriorly by the lips, and posteriorly it extends up to these arches, which are the palatoglossal arches. These are formed by the muscle of the same name, the palatoglossal muscle, which is covered by a fold of mucous membrane of the oral cavity. So they form these arches. Everything behind this, that is the tonsil, and these palatopharyngeal arches are part of the oropharynx. So the oral cavity finishes at the palatoglossal arches. This is the hard palate, and hanging from the hard palate is a part of the soft palate which you can see out here, which is the uvula. Now let's start with what is the focus of this lecture, the tongue. The tongue is a mobile muscular organ which forms a part of the floor of the oral cavity. When you open your mouth wide and look at yourself in the mirror, what you see is the dorsum of the tongue, or the anterior two-thirds of the tongue, or the body of the tongue. Now let's explain these parts. If, like all those gangster movies, we were supposed to take the whole tongue out, that is what has been done in this particular figure. The whole tongue has been taken out and parts of it are being seen. Now, this part is the oral part which you're seeing in the oral cavity. This is the part which you can see, the oral part of the tongue. A large part of this posterior part of it, the posterior 1/3 of it, is not seen. And this part is the oropharyngeal part, and this is even behind. So just to give you an orientation of this particular picture before we start drawing it, this is the anterior 2/3 of the tongue. This is the posterior 1/3 of the tongue, which is the oropharyngeal part. Then here, this is what we know is the part of the laryngeal cartilages, the epiglottis. ठीक है? So ये वाला part oropharynx होगा और ये उसके भी पीछे और posterior to it and inferior to it होगा. I'll just orient you again to this, but let's start by first drawing it. Now, what we see when we protrude our tongue out is this. Oops, let's take a, since I don't have a pink, so I'm going to use this color. Let's start. So here would be the, anterior two-thirds of the dorsum of the tongue, which we see. On this, there is a midline septum or a midline groove. Sorry, groove, not a septum. There is a midline groove. The tongue is bilaterally symmetrical, right? Then further posteriorly, what is not really visible to us is this V-shaped sulcus. Oops, sorry. Is this V-shaped sulcus, which is known as sulcus terminalis. All right. At the tips of the sulcus terminalis is where the palatoglossal arches are present. Palatoglossal arch. The anterior two-thirds of the tongue is rough due to the presence of these papilla. The lingual papillas which are present. Behind the palatoglossal arches and behind the sulcus terminalis. Okay, the V of the sulcus terminalis points posteriorly, and at the tip of the V out here is a depression which is known as foramen cecum. Now, foramen cecum you've seen in another place. Please try and recall. Now, posterior one-third of the tongue has a cobbled appearance. Sorry. As you can see in this particular figure also, that the posterior one-third of the tongue has a cobbled appearance due to the presence of lymphatic nodules, the lingual tonsil out here. More posteriorly, as I just told you, is the epiglottis, posterior inferiorly. The epiglottis is joined or is connected to the posterior one-third of the tongue by means of a fold of mucous membrane, which is known as median glosso-epiglottic fold. On both sides of it is a depression, which is known as the vallicula. This is the epiglottis. And more posteriorly, and more lateral to the vallicula are these lateral glosso. Glosso is another suffix or a prefix which is used for the tongue. So glosso, epiglottic fold. And in between the median and the lateral glosso-epiglottic fold is present the vallicula or a depression which is present. Now, what you have to understand, although I am calling this as the glosso-epiglottic fold, one part of it is obviously attached to the epiglottis out here, but laterally it is not attached to the tongue. It is attached to the pharynx. So it's a misnomer. It should have been a pharyngeal-epiglottic fold, but what we call is, for ease of learning, that the epiglottis is connected to the pharyngeal part of the tongue by means of a median glosso-epiglottic fold and the lateral glossoepiglottic folds, and in between them is a depression which is known as the vallicula. So this is the anterior two-thirds of the tongue, which also forms the dorsum of the tongue, which is what you're seeing when you're protruding your tongue out. This is the tip or the apex of the tongue. Now, this part of the tongue, that is the posterior one-third, as well as this, the pharyngeal, the further posterior part of the tongue is not seen. How do we look at this if we have not taken the tongue out? So, if we were to pass a mirror inside the oral cavity and depress this part of the tongue, or the part of the tongue which we can see, which is in the oral cavity, the anterior two-thirds, if we depress it, then through this mirror, we would be able to see the posterior one-third of the tongue. Now, this is the pharyngeal part or the posterior one-third of the tongue. And further, this point is the epiglottis, right? And this is the fold of mucosa which is connecting. These are the mucous membrane, how it's getting connected to the epiglottis. So to see this posterior one-third and the posterior most part of the tongue, we need a mirror. We depress the anterior two-thirds of the tongue, pass a mirror with the handle through the oral cavity, and we can see these two parts, that is the posterior, the pharyngeal part of the tongue. In the oral cavity is present the oral part of the tongue, the dorsum, which forms the dorsum of the tongue, which is rough due to the presence of these various papillas. Now, how are we going to be seeing the tongue? Mostly when we are doing our sessions of head and neck, we are going to be seeing it in the sagittal section like here. So this is the, now let me give you an orientation. Now this is a section which is a median sagittal section, that is the axe or the cutting has been done through the sagittal suture. So here is the nasal cavity. This is the oral cavity. You can identify the maxilla, you can identify the hard palate, and this is the soft palate, and this is the overhanging of it, the uvula. This is the mandible with the teeth, and this is the bulk of the muscle which is being of the tongue, which is being formed by the genioglossus. Here is the geniohyoid and the mylohyoid muscles. This is the hyoid bone. This posterior part is the pharynx. Okay? This part is the nasopharynx, which is behind the nasal cavity. This part, which is behind the oral cavity, is the oropharynx. This is the oral cavity proper. So this is the oropharynx. And here is the larynx. And this part of the pharynx, which is behind the larynx, is known as the laryngopharynx. These are the cartilages which form the skeleton of the larynx. Here is the epiglottis, and this would be the thyroid, and here would be the cricoid cartilage. Now, it is this part of the epiglottis which we saw earlier in our section. This is the oral part of the tongue, which is the anterior two-thirds. This is the cobbled appearance, the posterior one-third of the tongue, and this is the epiglottis. So did you understand now? That's why we said this is the oral cavity, the part of the tongue in the oral cavity, and this is the part of the tongue in the pharynx, the pharyngeal part of the tongue, because this is the oropharynx which we are talking about. And from here we saw the epiglottis, which is the tip, which is forming the tip of the laryngeal cavity. We are seeing the epiglottis. So if we were to draw this also, because we would need to understand both these sections to understand further the various parts of the tongue, let's start by drawing a mandible. So let's take a black color. This is the cut section of a mandible. This is the tooth, and this is the cancellous part of the bone which we are going to be drawing. Out here, let's draw the hyoid bone again, which is seen in a cut section. Right? Let's put in the muscles. Because of the, again, I don't have the brown, so I'm going to be using this dark red for my muscles. This is the mylohyoid muscle. On top of it would be the, from the inferior genial tubercle again to the body of the hyoid would be the geniohyoid. Oops. So this is the mylohyoid, and more cranially is the geniohyoid. Okay. Then forming the bulk of the tongue is the genioglossus, which is arising from the superior genial tubercle. So fan-shaped muscle, you've already done it, we'll be doing it again, forming this entire tongue, the oral part. the pharyngeal part, and out here we put the laryngeal cartilage, the epiglottis. Okay, and since this is the mucous membrane of the tongue, which would go like this. Okay, and this would be the folds. So here what we've drawn is, I've traced the mucous membrane, this mucous membrane which is present on the top of this muscle, the genioglossus, which arises from the superior genio tubercle. So ये bulk जो बना रहा होगा वो muscle का bulk होगा, which will be the genioglossus. ठीक है, so वो ऐसे जा रही होगी. These are its fibers. I'll talk about them. And over it, overlying it, is this mucous membrane which is forming the tongue. So now what are the parts of the tongue? This was the part which we were seeing, the anterior 2/3 of the tongue, which faces the hard palate. So which would be facing the hard palate out here. And it forms the dorsum of the tongue, and it also forms the body of the tongue. The part of the tongue which is between the mandible and the hyoid bone out here. This part of the tongue. Oops. How do I go back? So this part of the tongue, which is present between the mandible and the hyoid bone, and ये उसका posterior 1/3 है, ठीक है? ये जो posterior 1/3 of the tongue है, ये anterior 2/3 of the tongue है, ये जो posterior 1/3 of the tongue जो बना रहा है, which is present between the mandible and the hyoid, forms the root of the tongue. The blood vessels, the nerves, they enter the tongue through the root of the tongue. This is the body of the tongue, which is formed by the anterior 2/3 of the dorsum. This is the dorsum of the tongue. This was the tip of the tongue, and this surface is the ventral surface or the inferior surface of the tongue. The part of the tongue which is in the direction of the floor of the mouth. So these, again, this would be, if I was to put it in this figure, this would be the body. This would be the root. Here is the tip or the apex, and this surface is the ventral or inferior surface of the tongue. I hope you're drawing the diagram with me. Otherwise, it becomes difficult, right? So this here is the pharyngeal part or the posterior 1/3. This is the anterior 2/3 or the dorsum of the tongue. This here would be the oropharynx, right? This here is the oropharynx. This is the nasopharynx. And ये वाला जो part है वो laryngopharynx है. Okay? So this is what you have to understand when you see the sagittal section of head and neck. You have to be able to identify. The bulk of the tongue is made up of muscles. We have this line which we have traced is the mucous membrane of the tongue. The bulk of the tongue as well as its mucous membrane and whatever it contains, this anterior 2/3 forms the body of the tongue. This is the root of the tongue. ये dorsum or the anterior 2/3 of the tongue and ये posterior 1/3. The anterior 2/3 and posterior 1/3 are separated from each other by the sulcus terminalis, which was a V-shaped sulcus which we saw. And also at this point is the insertion of the palatoglossal arch or the muscle, the palatoglossal muscle, which is covered by a mucous membrane to form the palatoglossal arch. So this would be that particular part. Again, if you were to stand in front of the mirror and touch the tip of your tongue to the hard palate, what you would see would be the ventral or the inferior surface of the tongue. So here, again, please draw it with pink. I am drawing it with this particular color, is the ventral or the inferior surface of the tongue when the tip of the tongue is pointing towards the hard palate or is touching the hard palate. In the midline, you would see a fold of mucous membrane. You see a fold of mucous membrane which attaches the tongue to the floor of the mouth, or which helps the tongue to move away from the floor of the mouth, which is the frenulum. This frenulum helps the tongue to be mobile because instead of being attached completely to the floor of the mouth, the tongue is attached only by means of this mucous membrane, which is the frenulum. So it has its mobility. In some individuals, this frenulum may be very large, or it may reach up to the tip of the tongue. In those people, we get a condition known as tongue tie and frenulectomy. Frenulectomy has to be done. That is, this frenulum has to be cut in order to free the tongue and to make their speech clearer. On the towards the floor of the mouth, this frenulum nearest there is a presence of this subcaruncle on this frenulum, right? On both sides of which on the subcaruncle frenulum, the subfrenulum caruncle, sorry, is present. That's right. The subfrenulum caruncle, on which is opening of the duct of submandibular glands. Okay, then more lateral to it on both sides, you see the deep lingual vein. Again, very important. A number of times in the movies you would have seen that when the patient complains of chest pain or angina pectoris, तब उसके मुंह में एक उसको एक गोली दे देते हैं जो वो मुंह के अंदर डालता है. That is known as nitroglycerin, which is a lipid soluble drug which immediately dissolves in the floor of the mouth with the saliva, gets absorbed by this vein, and can reach to the heart in less than 1 minute to bring about the vasodilation of the blood vessels. So what it does is that it enters into the circulation. It enters straight into the circulation and bypasses the GI cavity. Such mode of administration of drugs is known as sublingual administration. And the basis of the sublingual administration of drugs is this deep lingual vein, which is present on the ventral or the inferior surface of the tongue. More laterally, again there is a fold of mucous membrane which is known as plica fimbriata. Plica fimbriata. Okay. Now, when you look towards the floor of the mouth, see here, one would see the sublingual fold. In this are the ducts, multiple ducts in the sublingual fold. Are the openings of the multiple ducts of the sublingual salivary gland. So in the vestibule, if you remember, part of the oral cavity was the opening of the parotid duct. In the oral cavity proper, in the floor of the mouth, is the opening of the submandibular gland, which is opening in the subfrenulum caruncle, and the sublingual glands, which are opening in the sublingual fold, which is present in the floor of the mouth. So this is how the ventral or the inferior surface of the tongue looks like. So the tongue is made up of muscle. The bulk of the tongue is made up of muscle, and this muscle is covered by mucosa. But the mucosa of the tongue, as you've already seen, is different in different parts of the tongue. So again, if we were to make our section, just to be able to discuss the mucosa of the tongue once, though it will be done more in detail when you do histology, but for completion, let's do it out here too. So the anterior two-thirds of the tongue, now you can draw it quickly. You have the palatoglossal arches. This was the posterior two-thirds of the tongue. Anterior two-thirds was separated from the posterior one-third by means of this sulcus terminalis. Okay, this had a corbelled appearance, which we saw. Here was the lingual, this was the median septum, and the entire anterior two-thirds of the tongue has what we call as the lingual papilla. These are the lingual papilla are nothing but these are these are folds of mucous membrane which are present all over the tongue, which have different names to it. The most widespread is the filiform papillae. These filiform papillae are cone-shaped. And these are the ones which are present all throughout the tongue. Anteriorly, they are more transversely placed. Posteriorly, they are placed and I'm talking only about the anterior two-thirds, in the same direction, in the same plane like the sulcus terminalis. But the entire tongue is full of these cone-shaped structures, which are known as the filiform papillae. These filiform papillae do not have taste buds in it. These are more for mechanical function. These do not have taste buds in it, and they have the afferent nerve endings which are present in it. Interspersed between it, especially in its anterior part, especially near the tip as well as on the sides, are these next set of papillae, which are known as the fungiform papillae, which are mushroom-shaped papillae. Now, these are present at the tip, near the tip as well as the margins, and these have taste buds in it. These are mushroom-shaped papillae. Anterior to the sulcus terminalis are present, again, these pinhead-shaped structures which are surrounded by a trench or a moat. So you remember the old-time forts, they always had a moat around them. Similarly, there is this globe pin-shaped structure which is present, which is confined just anterior to the sulcus terminalis. These are large flat-topped structures, 7 to 12 in number, which are surrounded by this moat. So these are known as the vallate papillae. And adjoining walls, both of the trench as well as of the this structure which is present together, is called the vallate papillae. In this are present in a taste buds. So they are 7 to 12 in number, which are present anterior to the sulcus terminalis. So this is the sulcus terminalis, and this was the palatoglosal arch. Better developed in hare and rabbits as compared to humans. On the sides or the margins is present another group of papillae which is known as the foliate papillae. So these are the various papillae, which are nothing but projections of the mucous membrane, which may or may not contain taste buds, which are present on the anterior two-thirds of the tongue. The posterior one-third of the tongue has a cobbled appearance because underneath the mucous membrane are present lymphatic nodules. Collectively, they are known as the lingual tonsil. So the posterior one-third under the mucous membrane is present the lymphatic nodules, and together this entire group of lymphatic nodules is known as lingual tonsil and is part of the Waldear's lymphatic nodule ring, or the Waldear's ring of lymphatic nodules. All right. So the mucosa of the anterior two-third is different from the mucosa of the posterior one-third of the tongue. And why is there difference in this mucosa? Because why is there difference in all these structures which are being present, and what is the basis for it? Is that because embryologically the anterior two-third is different from the posterior one-third. Now let's come on to the main issue. What is forming the tongue? The muscles of the tongue. Now the muscles of the tongue are grouped into two categories, and these are the extrinsic group of muscles and the intrinsic group of muscles. Now what do you understand by that? The extrinsic muscles are those muscles which have their attachments outside. One of their attachments is outside the tongue. That is, it may be attached to the mandible, it may be attached to the hyoid bone, and from there it is moving on to form the bulk of the tongue. Whereas the intrinsic muscles are completely confined within the tongue. All their attachments are within the confines of the musculature of the tongue. It's not gaining any attachment to the bones outside. Number one. Number two, the extrinsic muscles are the ones which move the tongue. They give it mobility, whereas these alter the shape of the tongue. They are both four in number. They are both four in number. The intrinsic muscles are the superior longitudinal, the transverse group, the vertical group, and the inferior longitudinal group of muscles. Whereas the extrinsic muscles are styloglossus, hypoglossus, genioglossus, and another muscle which is the palatoglossus, which you've already seen. So the glossus, as I told you, is a suffix or a prefix which is used commonly with the tongue. So there are four sets of extrinsic muscles and there are four sets of intrinsic muscles. They are all of them are paired. Please remember, they are paired. I told you the tongue is bilaterally symmetrical. This side of the tongue is similar to this type of the side of the tongue, and they are both separated from each other by means of this lingual septum or the median fibrous septum, which is separating these two sides. Right? So we have four sets on one side and four sets of one on the other side of both the extrinsic and the intrinsic group of muscles. Now let's see these muscles in detail. You've already seen these glossus muscles in submandibular region, but we will recap it and redraw it again. So the extrinsic muscles of the tongue. So let's go back to the diagram which you would have done in the submandibular region. Let's draw the bony landmarks which we need for it. This is the styloid process, which is the part of the temporal bone. The lesser cornu, the body, and the greater cornu of the hyoid bone. And out here, let's draw the mandible, the cut section of the mandible. Cut section of the mandible and the mandatory. All right. Let's draw the dorsum of the tongue. I'm changing the color of the mucous membrane now because I need to differentiate it from the muscle. The anterior 2/3 and the posterior 1/3 of the tongue. All right. All right. So let's start with doing the muscles. The bulk of the muscles is formed by the bulk of the tongue is formed by a muscle which is known as the genioglossus. The genioglossus arises from the superior genial tubercle. A part of it forms the bulk of the tongue. A part of it goes and gets attached to the body of the hyoid. These are its lower fibers. Its middle fibers go all the way back up till the posterior part of the tongue. And its upper fibers go up to the tip of the tongue. So it is a fan-shaped muscle. A fan-shaped muscle which is forming the bulk of the tongue is the genioglossus muscle. When it acts, what is it going to do? It is going, this is its direction of pull of the muscle fibers. So the tongue is going to move towards the mandible and the hyoid, towards the root. The body of the tongue is going to move towards the root. As a result of which, the tip of the tongue is going to protrude outwards. So the genioglossus is a muscle which, when acting bilaterally, the posterior fibers pull the tongue forward, and together, they help to protrude the tongue outside. So when you're protruding your tongue, the muscle which is acting is known as the genioglossus muscle. This muscle is also known as, now let's complete some applied aspect about this muscle. This muscle is also known as the safety muscle because it prevents the tongue from falling back over the pharyngeal part and blocking the pharyngeal part, the oropharynx. So in anesthesia or during anesthesia, when we anesthetize the patient, the muscle loses its tone. As a result, there is a possibility, muscles lose their tone. As a result, there is a possibility this muscle would fall back and choke the patient. Hence, usually during anesthesia, an endotracheal tube or an airway is put. An endotracheal tube or an airway is put in the oral cavity, is put to depress this genioglossus muscle so that and to prevent it from falling back. This muscle is known as the safety muscle. If this muscle was to fall back, it would result in choking of this entire, it would block this entire passageway, the oropharynx and the larynx, and would result in choking. So in anesthesia, an endotracheal tube or an airway is always put. Number one. Another way to prevent this muscle from falling backward is to pull the mandible forward. If you pull the mandible forward, again, the genioglossus along with it would be pulled forward, right? So that is genioglossus, right? We've done its action. Now, moving from the body of the hyoid bone, the part of the body of the hyoid bone, as well as the upper surface of the tip of the upper surface of the greater cornu of the hyoid bone, is this muscle again, which you would have seen in detail in the last class, which is the hypoglossus. A quadrate shape muscle which moves from the upper surface of the greater cornu of the hyoid bone and the body of the hyoid bone to get inserted into the dorsum and the side of the tongue. This muscle is the hypoglossus muscle, and when it acts, it's going to depress the sides of the tongue and the lateral part of the tongue or the side of the tongue and move it towards the hyoid bone. So this can cause depression of the tongue. Arising from the anterior surface and the tip of the hyoid, of the styloid process, intermingling and inserting by intermingling with the hypoglossus is the next muscle, the styloglossus. It inserts by interlacing with the fibers of the hypoglossus and the inferior longitudinal muscle. It gets again inserted on the sides of the tongue. When it acts, it's going to pull the tongue. It's going to retract the tongue by pulling it backwards and slightly upwards. So this is the action of styloglossus. The fourth muscle, which we see, which inserts at the junction of the anterior 2/3 and posterior 1/3 of the tongue, coming from the soft palate, is the palatoglossus muscle. It is more a muscle of the soft palate rather than that of the tongue. Its main function is to depress the soft palate. But when it acts from the other direction, it can also elevate the posterior 1/3 of the tongue. So we have these four muscles. One, the genioglossus, which was pulling the tongue, the tip of the tongue outwards. When it was acting bilaterally, it was pulling the tongue outwards. This was the genioglossus. Then there was this hypoglossus, which is depressing the tongue onto the hyoid bone. Then there is this the styloglossus, which pulls the tongue backwards, and which retracts the tongue, and the palatoglossus, which elevates the posterior 1/3 of the tongue. So these are the various extrinsic muscles of the tongue. Now, they're not acting in singly. This is just to understand their actions. Usually the movements of the tongue is a mixture of a number of muscles which are going to be acting. Now, another thing which you have to understand is there is another muscle out here, right? Which was the geniohyoid, from the inferior genial tubercle, although not a muscle of the tongue, which meant from the inferior genial tubercles to the hyoid body of the hyoid bone, which is the geniohyoid, which is also the protruder of the tongue. So when we talk about the movements of the tongue, if we were to classify these muscles into various groups, this is how we would do. So the protrusion of the tongue is the function. So movements of the tongue, the protrusion of the tongue is a function basically of the genioglossus, that another muscle which may help it is the geniohyoid. Right? The retraction of the tongue is the function of styloglossus. Also, hypoglossus will assist it. The depression is by hypoglossus muscle and the elevation is by palatoglossus, especially of the posterior 1/3. Now, the styloglossus, if you were to make it act, so it was acting like this. Right? This was the function of the styloglossus. It was acting, and the genioglossus was acting more on the central part of the tongue, and it was lifting it up. So, styloglossus, तो lateral margin of the tongue को elevate भी कर सकती है. It not only retracts but also elevates the lateral margin of the tongue, and the genioglossus protrudes the tongue. Together they can form this trough-like structure which is made in the center of the tongue. That is, it can also change the shape of the tongue along with the other muscles, the intrinsic muscles which were changing the shape of the tongue. So that's what I wanted you to understand, that most of these muscles act together, not individually. Now, let's see the intrinsic muscles of the tongue. We are not going to do the details of these intrinsic muscles, but we should understand the placement. So this is the coronal section. Again, this is the coronal section, which we are seeing. This is the maxilla with the maxillary teeth, the mandible with the mandibular teeth. Then this was the mylohyoid, the anterior belly of digastrix in front of it, the geniohyoid, the cut sections of geniohyoid. This is the genioglossus, which is forming the bulk of the tongue. This here would be the cut section of the styloglossus which is coming in, and this would be the hypoglossus which you are seeing. Now, between the mucosa of the tongue and the genioglossus are present first the superior longitudinal muscles. So, just below the mucosa is the superior longitudinal muscle, and more inferior to it, or inferior to that, is present the transverse and the vertical group of muscles. Medial to the hypoglossus is the inferior longitudinal group of muscles. So this here is the inferior longitudinal group of muscles which is present. So the intrinsic muscles, this is the superior longitudinal just below the mucosa, the transverse and vertical group, and the inferior longitudinal which is medial to the hypoglossus, and it lies between the genioglossus and the hypoglossus, and it is present medial to the hypoglossus muscle. So if we were to look at the entire tongue in totality, what you would see in histology, you would see that it has this mucous membrane, which would be the epithelium. Underlying it would be the submucosa. And this would be the bulk of the tongue, which is formed by the skeletal muscle. And plus, along with it, it would have these various glands, which are the the lingual glands, which are also going to be present in it. What I need you to understand, why do I need you to understand the structure of the tongue, is that when we talk about the innervation, the parts of the tongue which we need to innervate is the mucous membrane. So we need some sensory nerve supply. You know, you can feel touch, you can feel hot temperature on the cold temperature on your tongue. Then you can also feel the taste. So we have sensory innervation, which would be general sensations like touch, temperature, or it could be special sensation, which is the taste sensations, right? Then you would also need to innervate these skeletal muscles. So we would need a motor innervation for it. Plus we need to innervate these glands. So we would need a secretor motor nerves also coming to it. So not only would it need the it would need the autonomic nervous system to supply it. Also, which would be responsible for its taste as well as the secretion part of it. Plus, we would have the general sensory and motor nerves which will be coming to supply it. So we need to understand first, these are the components of the tongue which we need to supply before we go on to the innervation. But before we go there also, we need to understand what are the structures which are going to be in the vicinity of the tongue to be able to supply it. Again, go back to the diagram which you drew in the submandibular region. Let's draw the mandible. Sorry. Let's draw the mandible. The hyoid bone. Right? Let's draw the hypoglossus muscle. Sorry. Let's draw the hypoglossus muscle. the tongue, so the mucous membrane of the tongue, the genioglossus muscle which is going into it, the geniohyoid. Just completion, let's just draw the geniohyoid out here. Then let's also draw the styloglossus muscle which is coming from somewhere here and interdigitating. All right. So at the tip of the tongue, at the tip of the hyoid bone, you would remember, if you remember, the lingual artery, which is a branch of the external carotid artery, which is a tortuous vessel, is related to the tip of the hyoid bone, and at the tip of the hyoid bone, it goes posterior to the hypoglossus muscle. That is, it is lying between the hypoglossus. It is lying in between the hypoglossus muscle and the genioglossus muscle. So I'm going to be drawing it in a broken line because now it's gone posterior to the hypoglossus. What we are seeing here is what we are towards this is the superficial surface of the hypoglossus. So posterior to it, so we're going to draw it in a broken line. While it is posterior to it, it gives rise to these dorsal lingual branches which go on to supply the margins and the dorsum of the tongue. So this here is the lingual artery, which is a branch of the external carotid artery. It goes posterior to it, posterior to the hypoglossus, gives rise to the dorsal lingual arteries. Then at the anterior border of the hypoglossus, it emerges and takes a sharp turn upwards, lying on the genioglossus muscle. Here, it gives a branch to the sublingual salivary gland, which is present out here, which is the sublingual branch, and then continues up to the tip of through the bulk of the muscle up till through the genioglossus to go up, reach the tip. So if you remember this diagram in which we saw the inferior surface, here was the frenulum, here was the deep lingual vein. The lingual artery, although not visible to us on the surface when we look in the mirror, would be present out here. And this part of the lingual artery, which we are seeing, which took a bend out here, is the deep lingual artery. And this branch is the sublingual artery. The entire vessel is tortuous. So it is one of those vessels which are tortuous, and the reason for this tortuosity is that it needs to, because it's supplying a mobile organ. The other blood vessels which you saw was tortuous in this vicinity were the superficial temporal, the facial arteries. These are all tortuous blood vessels. So one more example of a tortuous blood vessel would be the lingual artery, and it gives rise to the dorsal lingual artery branches, the sublingual, and continues as the deep lingual artery towards the apex. Now, there is no anastomosis which is present between the blood vessel of the right side with the blood vessel on the left side across the fibrous septum, except at the tip. So that lingual septum which we saw is an area of is an avascular plane area. It can be an incision can be made in it during glossectomies. You can make an incision which is here because it's an avascular blood plane. All right. So that is about the lingual artery, which you will see, which you saw in the vicinity of this area. Now, over the lingual artery, crossing the lingual artery and moving superficial to the hypoglossus muscle is the next nerve which you are going to be seeing, which again pierces, which pierces the genioglossus and supplies it. This is the hypoglossal nerve. It gives rise to branches which supply all the muscles. So all the muscles of the tongue, the extrinsic as well as the intrinsic, except the palatoglossus, are supplied by the hypoglossal nerve. And this nerve branches and supplies it. It also gives a communicating branch, if you remember, to another nerve which is running superficial to the hyoglossus, the lingual nerve. May not take it out of the oral cavity. So the lingual nerve. And from the lingual nerve, superficial to the hyoglossus, was hanging the submandibular ganglia. If you were to trace the lingual nerve backwards, so it exits out in the mandibular nerve from the foramen ovale. The mandibular nerve, after exiting out from the foramen ovale, divides into an anterior trunk and a posterior part. The posterior part gives rise to the lingual nerve. Posterior division gives rise to the lingual nerve. So this is the entire mandibular nerve, which has given rise to the anterior division and the posterior division, and this is the lingual nerve, which is a branch of the posterior division. While it's in the infratemporal fossa, it is joined by another vein, which joins it at by another nerve, which joins it at an acute angle, the cauda tympani, which is a branch of the facial nerve. It comes and joins at an acute angle with the lingual nerve. Now, this is important because all these nerves have some role when we talk about the innervation of the tongue. So, we've seen the arteries, which is the lingual artery, which supplies the blood vessel. In case there is a lot of bleeding which is going to take place from the tongue due to any lesion, and that particular time, or due to a bite, or say during fighting, somebody hits somebody on the mandible and that person bites the tongue, or during an epileptic seizure, the person bites their tongue. So which would result in incessant bleeding from the tongue. To stop that bleeding, what you have to do is you have to press the tongue posterior to the site of the bleeding. So this is important to remember while trying to give first aid during bleeding from the tongue. Okay, so that was lingual artery. We've done the nerves which are present. We talked about the hypoglossal nerve, the lingual nerve, as well as the cauda tympani. Now the veins. This vein, which we see out here, which is present in the which was present on the inferior surface, is the deep lingual vein. So the deep lingual vein moves from the apex. Again, a branch of the a sublingual vein, a tributary of the sublingual vein joins it. Together, it forms vena comitatus, which are present, which run along the hypoglossal nerve. The hypoglossal nerve is the only nerve in the body which has veins running along with it, two vena comitatus running along with it, which are tributaries of the deep lingual vein. So the lingual vein arises from the apex. It is joined by the sublingual vein. Together they form vena comitatus, which run along with the hypoglossal nerve superficial to the hyoglossus, joined together. Oops. They further meet the branches, the tributaries which are running with the dorsal lingual artery, which run with the lingual artery per se, and all these join together. Oops, sorry. All these tributaries join together to form the lingual vein. They join together to form the lingual vein, which is formed by the deep lingual vein, the vena comitatus of the hypoglossal nerve, as well as the dorsal lingual veins, which are running along with the dorsal lingual artery. All these join together to form a single trunk near the tip of the hyoid bone, or individually, these veins open into either the facial vein or into the internal jugular vein directly. So with this, we've discussed the blood vessels, that is the arterial as well as the venous drainage of the tongue. The lymphatic drainage. The lymphatic drainage is very, very important because obviously the tongue is a site of carcinoma. Squamous cell carcinoma of the oral cavity are very common. Every time you've gone to see a movie in the movie halls, you have this initial clip in which they show some kind of squamous cell carcinoma of the oral cavity, which is due to alcohol or tobacco abuse. So the lymphatic drainage of the oral cavity of the tongue becomes very important because, as you know, most of these cancerous cells metastasize through the lymphatics, and the lymphatic drainage of the lymphatics of the tongue do not follow the blood vessels. So let's discuss the lymphatic drainage of the oral cavity. So let's draw the tongue again. This is the tongue. The lymphatic drainage of its tongue takes place in 4 sets of lymph nodes. I'll just draw those lymph nodes. One, lymph nodes are usually made in purple, are the submental group of lymph nodes, right? So here is the submental group of lymph nodes, which are present in the submental triangle. The submandibular group of lymph nodes, which are present near the submandibular gland in the submandibular triangle, and lymph nodes which are present along the internal jugular vein. So here would be the internal jugular vein, where it is crossed by the posterior belly of digastric. This would be the posterior belly of digastric. It has a group of lymph nodes. It has a set of group of lymph nodes which are known as the jugulo-digastric group of lymph nodes. Jugulo-digastric group. And where it is crossed, where is present the intermediate tendon of the omohyoid, there is present another group of lymph nodes, the jugulo-omohyoid group of lymph nodes. So the 4 important groups of lymph nodes are the submental, the submandibular, the jugulo-digastric, and the jugulo-omohyoid group of lymph nodes. Now the lymphatics which are draining can be divided into 4 classes. The apical group, the marginal group, that is which is coming from the margins, the central group, which will be coming from the central part of the tongue, which is adjacent to the fibrous septum, and the part which is coming from the I will use, what color should I use? And the part which is coming from the posterior 1/3 of the tongue. The lymphatics coming from the posterior 1/3 of the tongue, which would be the posterior, which would be the dorsal or the basal group. Dorsal or the basal group of lymph nodes. So we have 4 sets: the apical from the apex, the marginal from the margins, the central from the center of the tongue, and the dorsal or the basal group of lymph nodes. The apical group of lymph nodes drain, that is from the tip of the tongue. If there is a carcinoma there, it would drain, or normally the lymphatics drain to the submental group, to the submandibular group, to the jugulo-digastric, as well as the jugulo-omohyoid group. So number 1 thing to notice that the apical group is draining to all 4 cells. All right, that is an important thing we need to remember. Then, the marginal group, that is from the margins and the side of the tongue. The lymph would drain to the submandibular group, the jugulo-digastric group, as well as the jugulo-omohyoid group. From the central zone, that is which is present on the adjacent to the fibrous septum. Now the problem here is that from the tip, the central, and the dorsal or the posterior part of the tongue, the lymph drains contralaterally, whereas the marginal group drains only on the ipsilateral side, the lymphatics of the other areas drain on contralateral, both the sides, not only on the, so if there is the lymphatics of the right side would also drain, a part of it would also go towards the left side, especially for the central group, the dorsal, as well as the apical group. So but the central group on its own, on one particular side, drains into the submandibular group of lymph nodes, the juglo-homohyoid group, as well as the juglo-digastric group. The dorsal or the basal group drains into the juglo-digastric as well as the juglo-homohyoid group of lymph nodes. So the lymphatic drainage, while we talk about the lymphatic drainage, the important thing to remember is that there is, if we were to draw the tongue, supposed to be the medial septum. Now this part of the tongue, the central group, the tip, as well as this carcinoma here would have a bilateral drainage. So that means a carcinoma on one side, there is a possibility may spread also to the metastasize to the opposite side. Another important thing which we have to remember is that 50%, almost 50% of all these lymphatics which are draining from the tongue drain via the periosteum of the mandible. So during very early on, a carcinoma of the tongue may involve the mandible, may involve the mandible, may spread to the bone also. Right? So the lymphatic drainage, for lymphatic drainage becomes very important because carcinoma of the tongue is very, very important. So you should know this in detail. So we've already discussed the nerves which are in the vicinity. Now let's see how are these nerves, and we've also discussed what needs to be supplied. We need to supply the skin, the mucosa, and when we are supplying the mucosa, we need to give it a general sensation, general sensory supply nerve, which is going to carry sensation of touch, temperature, pressure, and other modalities, as well as a special nerve which is going to carry the modality of taste. We also need to talk about the motor supply of the tongue. So all the muscles of the tongue, except palatoglossus, are supplied by hypoglossal nerve. The palatoglossus, however, is supplied by the pharyngeal plexus of nerves, which is formed by the cranial part of accessory, the vagus, as well as twigs from the glossopharyngeal nerve. So that is extrinsic and intrinsic musculature of the tongue. Everything is supplied by hypoglossal nerve except for the pharyngeal plexus. Coming on to the sensory part. So let's draw again that simple diagram of tongue, which now you should be well versed with. The palatoglossal arch, the anterior two-third, the sulcus terminalis, and then the posterior one-third of the tongue, the median glossoepiglottic folds, the epiglottis, the lateral glossoepiglottic folds with the vallecula in between. Now let's divide the tongue, since it's bilaterally symmetrical, into two parts. Right? On one side, we will talk about the sensory, we will talk about the general sensations. Oh, sorry, need some place here. We will talk about the general sensation. And on this side, we will talk about the special sensations. That is for taste. The anterior two-third of the tongue. And this is the posterior one-third. And this is the posterior most part of the tongue. Right? So this would be the posterior most region, or the posterior inferior part of the tongue. Now the general sense, I need to draw one more thing before we go on. Let's draw the valate papillas which were present, because they have a special nervation. The general sensation of the anterior two-third of the tongue is carried by the lingual nerve. The that of the posterior 1/3 of the tongue, as well as from the part of the tongue which is overlying the circumvallate papilla, is carried by the glossopharyngeal nerve. And the posterior inferior part, the posterior most part of the tongue is supplied, the special sensation is by the internal laryngeal nerve, which is a branch of the superior laryngeal nerve, which is a branch of the vagus. Right? So the general sensation is carried by the lingual, which we saw, it came into the vicinity of the tongue, the glossopharyngeal, which crosses over the stylopharyngeus muscle, which comes with the stylopharyngeus muscle and then is present on the posterior border of the hypoglossus. So on the posterior border of the hypoglossus, please remember, pick up your submandibular region on a diagram. Another one which we drew from the book, please see, because I forgot to mention the glossopharyngeal, which is present on the posterior border. Please draw the glossopharyngeal. When you draw it on the posterior border, you will see that it is in close vicinity to the posterior part of the tongue, or the pharyngeal part of the tongue, and you will understand why the glossopharyngeal nerve is supplying this part of the tongue. And the posterior inferior, or the most posterior part of the tongue, is supplied, the general sensation is by that of the internal branch of the sublaryngeal, superior internal laryngeal nerve of the superior laryngeal nerve, which is a branch of the vagus. The taste sensation from the anterior 2/3 of the tongue is carried by the chorda tympani. So the fibers go via the lingual nerve, they are transferred to the chorda tympani, which it was meeting at an acute angle. And for that of the posterior part of the tongue, posterior 1/3, is again glossopharyngeal, including the part of the mucosa which is present over the circumvallate. And the posterior most part of the tongue out here is the internal laryngeal. On both sides, the internal laryngeal here. So out here would be the glossopharyngeal for special taste, for taste, sensation of taste. And here would be the superior laryngeal branch of the internal laryngeal branch of the superior laryngeal nerve of the vagus is going to be supplying the posterior. This would be the special or the taste sensation. The secretomotor fibers to the glands which are buried in the tongue, those anterior lingual glands, or the posterior lingual glands, come via the glossopharyngeal as well as the vagus, whichever is the nerve which is supplying, whichever is where in close of the glossopharyngeal or the vagus gives rise to the secretomotor fibers. So this is about the innervation of the tongue. Please remember that you need to understand the innervation of the tongue very, very well. And you need to correlate this with development once you've done development of the tongue. Now let's discuss the last competency of this particular lecture, which is the hypoglossal nerve. The hypoglossal nerve, as you've been able to make out by now, is a motor nerve which arises from the medulla oblongata in the posterior cranial fossa. It exits the posterior cranial fossa through the hypoglossal canal. So this is the hypoglossal canal. We are making a diagrammatic representation. So the depths are not taken into consideration. Somewhere here would be the foramen magnum, and this would be the jugular foramen. So it's sandwiched between these two is the hypoglossal canal. Through the jugular foramen exits the internal jugular vein in its posterior most compartment. In the intermediate compartment is the 11th cranial nerve, the 10th cranial nerve, and the 9th cranial nerve. And most anteriorly is the inferior petrosal sinus. These are the structures which are present in the jugular foramen. Now also present in the vicinity. So this would be the area of the jugular foramen from which is entering the internal jugular vein. And more anteriorly, you can see is present the internal carotid artery and branches of the external carotid artery. So this would be the anterior aspect of our diagram. This is the posterior aspect of our diagram. These are the medial structures. This is the medial, and what we are drawing is the lateral part. So let's put in the internal carotid artery, which is on its way to the carotid canal. We'll just draw a piece of it. And the branches of the external carotid, this is the superficial temporal. the maxillary, the facial, the maxillary, okay, the superficial temporal, the maxillary, the facial, the lingual. On the opposite side, we have the posterior auricular as well as the occipital. The rest we are not drawing. So the hypoglossal nerve exits through the hypoglossal canal, comes to lie in the groove which is present between the internal carotid artery as well as the internal jugular vein, comes lateral to these structures, lateral to the vagus, comes lateral to the internal carotid artery, loops over the occipital artery, enters in the carotid canal, the carotid triangle, exits through the carotid triangle by looping over the lingual artery, lies superficial to the hypoglossus, where it is accompanied by two vena comittantes, pierces the genioglossus and ends by supplying all the extrinsic muscles, intrinsic as well as the extrinsic muscles of the tongue. Right? So this is how we've seen is its course. Now, while it comes into the neck, the C1 fibers, some of the C1 fibers hitchhike with it and then exit as the descending branch of the hypoglossal nerve or the superior root of the ansa saphicalis. Some fibers, however, continue. These are the fibers which will supply the geniohyoid as well as the thyrohyoid. So the branches include, these are the C1 fibers which are hitchhiking through it. This is the superior root of the ansa. These are branches for the thyrohyoid, the geniohyoid, and it supplies the intrinsic and extrinsic muscles of the tongue. So it's a purely motor nerve. Now some fibers of C1, some fibers from the C1 hitchhike and enter back through the hypoglossal canal. These are the meningeal, this is a meningeal branch for the dura mater, which are fibers from the C1. Now purely being a motor nerve, it is supplying all these muscles which we talked about. Right? Now let's see what happens when this nerve gets injured. Now how does this nerve get injured? Now it can get injured by stab wounds in the neck, through cerebrovascular accidents which may result in loss of supply of blood to its nucleus. It may get injured even by some tumors, meningiomas, which are arising in the posterior cranial fossa. Now if it gets injured, that means there is paralysis of the muscles of the tongue which we can elicit. So we ask the patient to protrude his tongue. Normally, when the patient protrudes his tongue, when you ask the patient to protrude the tongue, both side muscles of the tongue are acting, and as a result, when the genioglossus acts, it protrudes the tongue and the tongue is symmetrically protruded out. However, in case one side hypoglossal nerve gets damaged, so when the injury is unilateral, that is here, the right side hypoglossal nerve has been injured, you can see that the right half of the tongue is atrophied due to disuse, as well as there is wrinkling of the tongue. On the left side, it's all normal. Now, when the patient is asked to protrude the tongue, the right side genioglossus is not going to be acting, but on the left side, it is intact. So this will protrude the tongue. The left side genioglossus will protrude the tongue, but it is not supported by its right side counterpart. As such, the tongue deviates towards the affected side, as if it's licking the wound. You know, the tongue is the most curious structure which is present in the oral cavity. The moment you have a lesion, it will invariably go and lick that particular part. So the mnemonic with which we remember this is that the tongue is licking the affected side. So you have to remember that when there is a unilateral paralysis of the hypoglossal nerve, the tongue deviates towards the site of injury, In bilateral cases, the tongue is motionless. All right. So with that, we come to the end of this lecture. Hopefully, you've now understood the anatomical basis of hypoglossal nerve palsy. And please remember that the tongue, its nerve supply, its musculature, most of it is a very important question. So please prepare for it.